I'm so happy to be presenting in front of all of you today about what I do. So vascular surgery, it's one of those fields that's, there's not a lot of vascular surgeons in the nation. And so even, you find that even some providers don't even know what we really do. And then it's so diverse, it's hard to even, have like a small talk with somebody like, oh, you're a vascular surgeon. It's like, what do you do? It's like, well, I just say arteries and veins, like all issues, blockages, diseases of arteries and veins. And then usually people just stick to veins, like you do veins. It's like, yeah, but I also do artery stuff too. So it's just kind of interesting to try to summarize it, which I'm never good at. So I think, and I just figured this out on the walk over here, I think I'm just gonna go head to toe and just go over like what I do in each part of the body. And maybe that'll be like a little bit more focused and easy to follow. So first off, the head, off limits to me. So like, especially when it comes to anything intracranial, which you still have the arteries and the veins in the brain. And so sometimes I get referrals for like carotid disease, but it's the carotid that's intracranial, and that's not my territory. That's neurosurgery, also interventional radiology or interventional neurology. They do all the stroke stuff. They do the thrombolytics and the coiling of aneurysms and things like that. They do that. We are not in that arena. However, on the face, when it comes to giant cell arteritis or temporal arteritis, so when people come in with, severe headache, jaw claudication, maybe even some blindness, that's kind of an emergency, right? You get them to the emergency room. And then a part of that workup is getting a temporal artery biopsy, and that's to confirm the diagnosis of giant cell arteritis. The important thing for that is that the temporal artery biopsy is not a treating, surgery at all. We're not treating anything. We're just confirming a diagnosis. So that's probably the highest place that we go, and usually the temporal artery biopsy is right there. Next, the neck. So the big thing for us, carotid disease, so carotid artery stenosis. You can even have some aneurysmal disease of the carotid arteries, so when the arteries get too big. That's usually pretty rare, usually associated with an injury, especially like a traumatic injury. And so for carotid arteries, we usually do either carotid endarterectomy, that's where we actually clean out the plaque of the artery, or we can put a stent there too. The procedure that most vascular surgeons do these days is called TCAR, which is we make the incision on the neck and actually access the artery directly to place a stent. What's really cool about this procedure is we actually have this device that reverses the blood flow while we're doing the procedure. So the major risk of the procedure is a stroke, right? Because you're usually using the wire to get past the blockage, and that can flick off pieces of plaque to the brain. But we have this device that we hook up, and it reverses the blood flow. So any plaque that would go to the brain actually goes into the device, and then we connect it to the vein in the leg. So there's like a filter catcher in the device, and then whatever blood flow that's left over goes into the leg. So that's what's really nice about that. The traditional way that the stents are done, and a lot of people still do it these days, is transfemoral stenting. And that way they don't have a flow reversal device, but they have to manipulate past the plaque to place a filter to catch plaque while they're doing the procedure. So you still have that risk, a little bit of increased risk of stroke compared to ENDART and TCAR because of that. So that's what's interesting about that. When it comes to the veins in the neck, like the internal jugular vein and external anything, usually it's just clots when it comes to the veins, and there's not really any procedure we do for that. We just recommend anticoagulation. Now, I will mention here that we also work with dialysis patients. And so what they usually, when they are just getting initiated on dialysis, they usually have a catheter that they place, perm cath. We do those. Also, interventional radiology does them. Even some general surgeons do the kind of the tunnel catheter for that. But what we also do is we create dialysis access for them. And so that's where I'm going to come to the arms. So usually we connect an artery and a vein in the arm, or we place a graft in the arm for dialysis access, just because during hemodialysis they need this high flow of blood flow in order to exchange the blood. And so you just can't use the vein because it'll just collapse when you're drawing blood that fast. And so that's why we connect the artery and the vein, build up the vein, have the blood flow of the artery, but yet none of the complications of actually accessing the artery in order to get dialysis. And the nice thing about the dialysis access or arteriovenous fistula or AVF is that there's basically an extremely low risk of infection versus a catheter that's, in your neck, or even a graft. It does have a little bit of a higher risk of infection when it comes to that. So moving on from there, now I guess we'll get to the chest, and we can still kind of cover the arms too, but in the chest and the arms, you might have, I'll start with the arteries. So you might have aneurysmal disease. So when it comes to ascending aortic aneurysms, that's not my territory, actually. That's cardiothoracic surgery. So, and then in a kind of arch disease like that, that's cardiothoracic surgery. So they're the heart and the ascending aortic surgeons. But then when it comes to the descending aorta in the chest, because it kind of looks like a candy cane coming off the heart. When it comes to that descending part, that's where it kind of gets into our territory. So you can have occlusive disease where it's like plaque buildup and blockages. You can have aneurysmal disease where the artery is just too big. You could also have traumatic injuries, which we also treat those as well, especially like blunt traumatic injuries when you get in a car accident or something like that. That can happen in the aorta. Just coming off the aorta, you also have the subclavian arteries, which that goes into your arm. So you can have blockages that are there. They can also be kind of in your arm there too. And when it comes to blockages, I would say overall the way that we treat them is either there's the endovascular way, using wires and catheters, balloons and stents to open it up, or there's the open surgical way where we either open it up, clean it out, or bypass it. And so when it comes to these blockages, if we can't do it endo, we usually have to do some kind of bypass for that artery. And then, going on to the arms, you might have some blockages there too. Rarely is there aneurysmal disease in the arms. And then when it comes to the veins in the chest and the arms, you can have blockages when it comes to that. An interesting one is like something like Paget-Schroeder's disease. That's somebody from, and this is when we usually see younger patients because they're just like overusing their arm, and they might have some kind of anatomical deformity like a cervical rib, or even just using the arm that much with muscles and everything. It can compress the vein that goes into your arm and cause a clot in the arm. So that's one of those situations where sometimes they might go to the emergency room and then they get started on anticoagulation, but that's one of those situations that we would actually take them to the OR or the cath lab to actually drip some medication to get rid of the clot. We would take them back the next day and then check actually different positions to look at the blood flow. And that would actually confirm a diagnosis of either a cervical rib or some kind of compression syndrome that's causing the clot. So, and then that goes further. So after the clot is resolved, then we would do something like a rib resection or something like that to make sure it doesn't occur again. So that's just there, right? And then we're going into the belly. And so that's where we get into kind of aneurysmal disease, AAAs. We have aortoiliac occlusive disease, so blockages of the aorta and in the arteries that go into your legs. Same thing, the way that we fix them, either open up, clean them out, or bypass them with the graft. And that's, that's pretty much it. So, and it really, when it comes to the decision on which one to do, it depends on not only the patient and what other disorders or diseases that they have, whether or not they can withstand a certain surgery, but also just the anatomy of the plaque, which is different for everybody. That's what makes it kind of interesting for me, is because I get to look at these images and find out, okay, what would be the best thing for this patient? Like, yes, it's the same issue as the person that I just saw, but it might be a completely different way that I have to treat it. And then there's also the arteries that go to the gut That's where we go into the chronic mesenteric ischemia or acute mesenteric ischemia. That's when you get a blockage in the artery that's going to your gut and you get pain in your belly. This is also one of those kind of vague pain syndromes. So usually people get pain like 30 minutes after they're eating, which is associated with a lot of different things, right? Like you can have gallbladder disease and that causes the same thing, but usually it's a kind of a long-standing thing. You'll get, pain 30 minutes after eating, then it resolves. You start to actually lose weight because you're just not eating as much, even food fear. That's kind of all associated with having blockages in the arteries that are going to your gut. Now, if it was something that suddenly happened, like an acute mesenteric ischemia, that's just sudden pain that occurs. And it's pretty notable. Most people will go to the emergency room immediately. And then now going into the legs, you have, of course, blockages and aneurysmal diseases in the legs. So same thing, either minimally invasive treating or open treating with bypasses. What I didn't mention was the veins from here down. So veins, you can still get clot, of course, in the veins here. DVTs, I think that's probably what people are most familiar with. And that's just getting a clot in your legs. So sometimes, we just give them blood thinners and, kind of send them on the way. However, when the clot is actually more extensive and it comes up into the belly, or if the symptoms are really severe, even with blood thinners, we would actually do a procedure for that called it's percutaneous thrombectomy. We actually have this device that takes out the clot in the veins in the legs. And then sometimes there's some disease, like some kind of compressive disease that's also causing the clot, so you might put a stent in the veins for that too. There's also some other vague things like pelvic congestion syndrome or nutcracker syndrome. That's usually younger women, mostly associated with when they have like varicose veins in their pelvis. It's actually causing pain. A lot of times associated with pregnancy. I usually see it after or during or after getting pregnant. Some people are just unfortunately plagued with this and just want to just add another thing to what happens to your body after you get pregnant, but there's some things that we can do to treat that too. I think I went from head to toe. I think that's it.
With some of what would you say patients come to you just not knowing necessarily what's happening, or what symptoms do you see that are bothering people enough to schedule with them?
Yeah. So I would say majority of what I see around here is either carotid disease or peripheral arterial disease. And what I say about around here, I mean in Nebraska, because I'm coming from Texas. So we just didn't have as much carotid disease. There's a lot of carotid disease around here. But when it comes to the legs, usually when it's blockages in the legs, it's pain after walking a certain distance. So usually they're fine at rest, but then let's say they walk a block and then they start to get cramping leg pain in their calf or their thighs. And then it goes away when they rest, and then they get back up and walk again, and it occurs at the same distance. So that's the kind of pain that's associated with that. When it comes to veins, which there's a lot of venous disease, and that's everywhere. Usually it's I'm on my feet all day, and at the end of the long day, my legs are swollen, and I have this heaviness, aching sensation in my legs. And then it goes away when I wake up in the morning, and then I get back up and it happens again. And it's usually after a prolonged period of sitting or standing that you would start to get that heaviness pain. It might even be associated with like some numbness sensation. A lot of times there's restless legs is one of those things that it's really hard to figure out what's going on. Sometimes, I would say maybe 25% of the time, my patients will come back and say, oh, you know what, my restless legs are better too. So, I wouldn't really want to associate it with it, but if it's paired with all the other symptoms, I would say, yeah, there's a possibility that the veins could be contributing to that too. And then varicose veins, the veins that bulge out, and then just pain associated with the varicose veins, you most likely have reflux, and that's something that we could treat too. Carotid disease. So, unfortunately, carotid disease it's pretty silent. Some people, which unfortunately or fortunately, they have what's called a TIA, or a transient ischemic attack, and that's like a few seconds of, let's say, my arm gives out, or it's numb, or weakness, or something like that. But then it only happened for 10 seconds, and it went away, and then you're fine. a lot of people ignore it. They're like, yeah, whatever. But that actually might be a symptom of carotid disease. So that's a reason to let your primary care doctor know, so they can order the appropriate studies for that. A lot of people are like, oh yeah, that happened a few years ago. And then, they had this major stroke 3 years later. And, maybe we could have caught it before they had a major stroke. So that's another common thing.
So many lifestyle things or things people can do to avoid seeing the amazing you are. Like these things just really, maybe it's in your genes or in your body or.
Well, especially when it comes to like plaque buildup in the arteries, and especially like I was saying, I've noticed a lot of people have carotid disease, but yet we never really saw. We did have carotid disease in Texas, but I think there probably is a genetic component to where your plaque goes. But there are definitely things that we can do to decrease just generalized plaque from building up, right? And unfortunately, we are all victim to the American diet, and we love our, fried foods and our fattening foods. But yet, there's been a lot of data coming out about actually vegans having even decreasing plaque in their arteries from their diet. So, which, I am not saying give up the meat, but I would say maybe make the meat a little bit less on your plate and make the vegetables without butter a little bit more, in just your daily diet. Smoking is one of those things. And I usually, anybody who smokes, of course they've heard all the bad things, but we always try to scare smokers with like lung cancer and things like that. But 100% of the time you're building up plaque in the arteries. It's just one of those things that causes inflammation in the arteries and is associated with that too. I had another thing that I was vaping, we don't have too much data on. I would say it still has nicotine. Nicotine is still causing inflammation in the arteries. So that's one of those things that we'll probably see in the future just because of our younger generation. But also let's just stay away from that. Having diabetes, that's one of those things that also just causes inflammation in the arteries, especially the tiny little arteries in your legs. It's very difficult to treat because we just don't have the technology to successfully treat these small vessels, especially the tiny little arteries in your foot. So unfortunately, these people end up with amputations a lot. Just having uncontrolled diabetes can cause that.
Do you do amputations?
Mm-hmm. Oh yeah, I didn't mention that. I try not to. That's like everything that I do is to prevent amputations, but unfortunately it does happen. So we also do the amputations as well too. Podiatry, usually they're with the toes and everything. We can still do the toes too if like there's not a podiatrist available, but we'll do different levels of the foot and the leg for amputations. Wounds. So yeah, that's another thing. So when people come in with wounds, especially, normally we all get wounds, right? We can, bump our leg, get a scratch. It should heal normally. But if it doesn't heal, if it takes a long time to heal, that's a reason to let your primary care doctor know so they can get to the wound care clinic. And then usually at the wound care clinic is where we start to work up, okay, why do you have this wound? Sometimes it could be venous disease, which can also cause this. It could be also arterial disease. It can be something just, infection. It can be anything. So we usually see a lot of patients that have wounds too, just because a lot of times it's associated with something vascular. That was a lot.
What do you love most about what you do?
No, God, no. It's just a sad day when I have to do an amputation. But the best thing, I would say, this is actually something that I kind of struggle with, right? Because I love to see good outcomes. Like I love when patients can come back and tell me like, oh, I was in pain and now I'm not anymore. Or, yeah, my wound is now well healed, and but unfortunately that's not the reality a lot of times, and then even I like immediate results, right? I'm a part of the immediate results, generation. Like I want to see things happen immediately. And so even if it takes time, it kind of disappoints me. So, but that's what I love to see. I love to see suffering to go away, so.
What kind of schooling did you go to?
Yeah, undergrad and then med school. And the general pathway is undergrad and then you go right into med school. However, I didn't do that. I did 3-year gap year of 3 years. And then in that 3 years, I did a master's program. And it was kind of because I didn't know if I really wanted to do medicine because I knew what a commitment it would be for my life. And so I was like, maybe I can teach or something like that. But in that program, so it was like a teaching kind of program. But in that program, I learned that I loved medicine. So, and then here I am. But then I did med school for 4 years. And then after that, you do residency. So whatever specialty you choose, it basically determines how long you're in residency for. It can be from 3 years to 7 years. I knew I was randomly assigned to vascular surgery in my 3rd year on my rotations, and I fell in love, unfortunately. And so I knew I wanted to do vascular. So there's some integrated vascular programs. They're kind of new, maybe from like the 90s, late 90s, early 2000s, but it's like a 5-year integrated program. With basically general surgery for your first 2 years, and the last 3 years are vascular surgery. So that's what I did. The more traditional pathway is like you do 5 years of general surgery, then 2 years of vascular. I'm so glad I did not have to do that. In my last year, I was like, I cannot do this anymore. I'm done. But yeah.
How often do you come to Lexington?
I come here every 4th Monday.
So if we have a patient that we feel would benefit from your services, do they call the clinic?
Yeah, I think they can call
Just call outpatient.
outpatient services. Yeah. Yeah. I think it's been pretty easy. Nobody's really said it's been too difficult to get in. I've even gotten some phone calls from some of the providers, and I'm like, yep. Sounds like they need to see me. Send them.